Guys, this is Mrs. Fisher. We're going to go ahead and go through the upper airway content for this module for respiratory, okay? So the first thing we're going to talk about is rhinitis. So rhinitis is the most common nose/sinus problem. It'll affect about 20% of the population. So rhinitis is when we get that drainage, that inflammation of the mucosal membranes in the nose. It's usually in response to like an irritant. You can have allergic or non-allergic rhinitis. So allergic would be like seasonal allergies, um, or non-allergic is just like having a runny nose. Perennial or seasonal. So perennials, like people that experience this irritation of their mucosal membranes and this irritation in their nasal passage with that nasal congestion year round. Or seasonal, like we just talked about, seasonal allergies. Your manifestations, your clinical manifestations you typically see are going to be like the nasal itching, sneezing, irritation to the eyes, nasal congestion, or that rhinorrhea, which is that drainage coming from the nose. Typically, that should be like clear, thin drainage. So, medical management, first we're going to look at diagnosis. So, you're going to talk about history and symptoms. So, you want to ask your patient those history questions. When did this first start? What's the duration? How long has it lasted? Do you experience the irritation, the burning, itching to your nose? The nasal drainage, is it clear and runny or is it thick and purulent? Do you have like any drainage that runs down your throat that causes you throat irritation? And then we can also do like pulmonary function testing. Usually, medical management for this is just symptom relief. We're looking at antihistamines, allergy medications, um, things of that nature. Do be aware that some medications can actually cause this rhinitis, like ACE inhibitors, aspirin, Viagra will increase blood flow, which can increase that rhinitis in the nose. You kind of see that like pregnant women too will get that increase in a runny nose due to that increase in blood flow and vasculature. As for like medication management for these, for that symptom relief, we can use those oral antihistamines. So, such as diphenhydramine or Benadryl is the brand name, is the most common used to treat. However, you can see those that take like the daily allergy meds, such as um, loratadine, sertrazine, which is like a Claritin over-the-counter meds typically. Do be aware that these oral antihistamines can cause drowsiness in your patients. Benadryl, loratadine, oral antihistamines can cause your patients to have kind of decreases in their mental status. It can cause drowsiness, lethargy. Advise your patients not to operate heavy machinery, drive, make sure they know how it affects them before they take it and then try to do something that could be dangerous if they were to get sleepy. Nasal sprays. So the nasal spray that I need y'all to know for this is fluticasone. Fluticasone, your patient's gonna spray it up each nostril. It's gonna help decrease that inflammation. So you're gonna get that decrease in the inflammation in the nasal passage. Be aware that we can sometimes get rebound congestion from medications that we're using to treat the airway in the nose there. So make sure you educate your patients to be using their medicines appropriately, only using that fluticasone as it's prescribed, because we can get some rebound congestion, but it is going to help decrease the inflammation in the mucosal membranes and help with the irritation that's the rhinitis is caused by. Okay. And then you've got decongestants, and that's going to help like break up that secretion and get them thin. Okay. So nursing management assessment and analysis. Irritation and inflammation. So first you're going to ask your patient about that irritation and inflammation. You can actually kind of look into the nares and see if they've got any redness, drainage coming out. Like I said, we should expect that nasal drainage to be clear and runny and thin. It shouldn't be thick and purulent and almost like infection-like, because then we worry that we've got infection going on rather than just something like a viral or seasonal allergy causing this rhinitis. Management-wise, we really want to work on like comfort of our patients, any knowledge deficits. So, like I talked about, educating them about rebound congestion, risk for infection. Like I said, being able to note your signs and symptoms to note that if this is rhinitis or if this is turning into something more like a rhinosinusitis. Some of those assessment things that we're going to look for risk for infection are going to be like if they've got an increased temperature. So that could be signs for infection if our increased temperature, if our temperature is elevated. So make sure you know to watch for that, so we can get proper diagnosis. And a lot of this, like I said, guys, is just management of a runny nose. So assessments, vital signs, peak flow rate, and nasal drainage. We just talked about all of those. So, watching for that raise in temperature, making sure that your patient is getting good airflow in and out of their nose, and then monitoring that their nasal drainage doesn't turn into something that looks infectious. Uh, Action is going to be administering medications as prescribed. Like we talk about, make sure we're using medications appropriately, so that we avoid that rebound congestion. Make sure our patients are educated on those medications, such as your antihistamines that can cause that drowsiness or changes in mental status, so that they are aware, that they make sure that they take it as prescribed, that they make sure they watch how it affects them before they go do anything while on that medication. That's going to be also in your teaching. You also want to teach them to avoid allergens or triggers. So if they know there's something specific like cats, pollen, something outside like that, that we make sure we've educated them on decreasing their exposure. And if it's something like a viral infection that's causing this rhinitis, make sure that we're preventing the spread of infection. So wearing masks, educating our patients, to cover their coughs or their sneezes, wash their hands appropriately. And really, our outcomes that we want here is that decrease in nasal drainage and congestion. If your patient presents with like a headache or irritation in their eyes, anything like that, that we see a decrease in symptom and symptom management. All right, moving on into rhinosinusitis. So, rhinosinusitis is symptomatic inflammation of the nasal and paranasal cavity. So that's where we're getting in to that paranasal cavity. You see this affect people, about 1 in 8 Americans experience this. It can be infectious or not infectious. That increase in permeability causes an increase in congestion and a decrease in the sinus size. So that inflammation is going to constrict the sinus down, and we know inflammation is causing more blood flow to the area, which is causing increased permeability, which is going to increase your congestion. It's going to make you get more of that excess mucus production in the nasal cavity there. So it's gonna eventually we get to the point where like obstructs the airflow. Y'all have all experienced, or I figure everyone has experienced having like a rhinosinusitis where you're so congested you can't breathe. You wake up and you're like, man, I took for granted being able to breathe because now I'm so congested that I can't breathe out of my nose and I've become a mouth breather. You guys have usually seen that, such as the clinical manifestations. They're mouth breathing. They've got that purulent nasal drainage, that, that snot or secretions that are coming out are yellowy or green, thick mucus. You've got that pain or tenderness like up in your forehead, down around your nose, like into your cheeks could be really tender. You get fatigue, headache. You could even see like dental pain. So like it works back up into your teeth, like ears, nose, and throats, that kind of all connects through there. So you could even have pain like back into your, like back of your mouth and your molars, cough. Your ears can feel full and stuffy. Your patients may complain that their ears feel full, stuffy. They feel like they can't hear very well. I figure everyone's probably either experienced this or has known somebody that has experienced this when they've got a rhinosinusitis. Okay, so medical management, diagnosis, physical exam, and history. Like we said, ask those questions. How long has this been going on? Have you been running fevers at home? What does the drainage look like? Is it causing you to have to breathe out of your mouth? And we can do radiographical imaging if we need to. So we could do like a head CT or something like that to determine if we've got like that true rhinosinusitis up into the the sinus cavities. especially if you were to see um, like orbital pain or orbital swelling or orbital cellulitis in that area, it would be really important to recommend or see about getting some imaging for your patient. That orbital swelling or orbital cellulitis is that swelling around the eyes that you get, that edema in the eyes or in the orbital area. So make sure that you know to assess for that because that is a big one that we would maybe want to go ahead and do some radiographical imaging for to make sure we haven't developed a more serious problem. Pain relief. So educating your patients on taking acetaminophen or Tylenol or ibuprofens as prescribed to make sure they reduce the inflammation and the pain of these symptoms. Remember, ibuprofen helps reducing inflammation and it'll also help reduce pain, but Tylenol is usually for pain and fever or acetaminophen. Reduction of that mucosal inflammation. So once again, things like that fluticasone help well to decrease that. You might also even see these patients go on like an oral corticosteroid. So we know corticosteroids also decrease that inflammation in the nose and in the nasal passage. So make sure that you know you could educate your patients on corticosteroids and the signs and symptoms of things like, and it's going to increase your infection risk. It's going to potentially increase your blood sugars, things like that. And then treating the infection. If we determine that this is infectious, your patient's probably going to go on a round of antibiotics. Remember, though, that we don't want to prescribe antibiotics for something that's not truly infectious because we do run the risk of creating antibiotic resistance in our patients if they take antibiotics when it's not necessarily needed. So make sure that we're not just giving our patients antibiotics willy-nilly for something that may not truly be a bacterial infection. If it's a bacterial infection, antibiotic is not going to do any good for them anyway. It's actually going to cause harm by potentially causing them to be resistant to antibiotics later on. Okay, complications. So like we talked about, that orbital cellulitis, orbital abscess, osteomyelitis, meningitis, sepsis, and subdural abscesses. So that orbital cellulitis is when that infection has gotten up into the orbital area. Now it's in the skin, it's causing that orbital edema. Orbital abscess, so it's like getting an abscess in the orbital cavities. Osteomyelitis is if the infection from the sinuses were to get into the bone. Meningitis is if it gets into the meninges in the brain, and in the spinal cord. Sepsis, obviously. So these potential infections could go septic. So we really need to make sure that we know our signs and symptoms of sepsis. And then a subdural abscess, the same kind of idea of getting an abscess in that subdural space there, guys. All of those would be considered relatively severe complications. We would really need to get some intervention and get that infection risk down to prevent things like sepsis or worsening infection. Make sure we know our bad symptoms there, okay? All right. So going back over rhinosinusitis, nursing management, we're going to assess with facial pressors. So we're going to feel around on those sinuses. So we're going to feel around on that forehead and into the cheekbones to check out those sinuses, see if we've got tenderness or pain. You want to see if they've truly got like nasal obstruction, like are they moving any air in and out of their nose, or is like one air more patent than the other? Looking for that purulent nasal drainage. Diagnoses, like nursing diagnoses for this could be risk for infection or acute pain. Assessments of vital signs. So we can have some changes in our vital signs here. Obviously, if we feel like we can't breathe, sometimes your patient can even get a little panicky, and we can see like increased respiratory rate if they feel like they're not able to get air in and out of their nose. Decongestants can actually increase your blood pressure a little bit, so be aware that you might have a little bit of an increase of blood pressure. And also if it is infectious or we do have like the inflammatory process going on, we might even see a little bit of an increased temperature. Make sure we're monitoring that though, like we said, so we're not seeing temperatures so high that we would suspect worsening complications like sepsis. And then percussion of the sinuses, like we talked about. And then nursing actions are going to be to administer those medications as prescribed. So that fluticasone nasal sprays, the Tylenol, ibuprofen, antibiotics, make sure that we are giving those appropriately and that we're educating our patients on appropriate use of those. That goes into the teaching here. So reporting symptoms, telling our patients, if they do start to experience that swelling in their eyes or a headache that just won't go away, or they start to have, changes to their vision or mental status or anything along those lines, that they need to report those symptoms. Talked about correct medication usage, that they are using it appropriately to not cause rebound congestion, that they also are aware that antihistamines can cause them drowsiness, decongestants can increase their blood pressure. Nursing management, evaluating care outcomes. So obviously our goal is that we want relief of nasal congestion and relief of symptoms. We want to see a decrease in pain and pressure, or even become pain and pressure free. We want to be free of infection or prevent a worsening infection, and ultimately we don't want to get into those worsening complications. We want to make sure that we don't progress into those. We want to try to get it stopped early. Okay. Obstructive sleep apnea. So most of you probably know somebody who has been diagnosed with sleep apnea or cared for a patient at this point that has sleep apnea. About 26% of adults have obstructive sleep apnea, and 90% of those go undiagnosed. Usually we're going undiagnosed from sleep apnea because people either don't have somebody that witnesses the sleep apnea. So say you live at home by yourself and you go to sleep and there's no one there to tell you that you're having these apneic episodes, and or people just don't seek treatment. They think, oh, I just snore and snoring's not a big deal. But if it's to the point that we're having obstructive sleep apnea, it is in fact a big deal. So some of the risk factors for sleep apnea are dysrhythmias, atrial fibrillation, dysrhythmias in your sleep due to that impaired oxygen, type 2 diabetes, heart failure, pulmonary hypertension. Typically, we see this more in males than we do in females. Obesity, or like having a larger neck, so that weight gain really puts you at risk for sleep apnea. Smoking cigarettes, alcohol use, especially before bed. Alcohol use, especially before bed, is a big one. Being age 40 to 65, craniofacial or upper airway soft tissue abnormalities. That's going to be like enlarged tonsils or adenoids, septal defects, things of that nature. We'll talk more about those. And postmenopause. Women that are postmenopausal are more likely to develop sleep apnea. Okay, so sleep apnea pathophysiology. So the upper airway is going to narrow or collapse, and it's going to increase resistance to the airflow. So when you go to sleep, everything in the upper airway and in your mouth relaxes. And when that relaxes in your sleep, your muscle tones relax. And so our normal work of breathing is not able to overcome that increased relaxation. So when everything has gotten nice and relaxed and still, and like everything droops down into the back of your mouth and throat, you don't have the normal work of breathing in your sleep to overcome that resistance to breathe harder. That's where you end up getting that collapsed airway. You'll get that snoring respiration where you hear that snoring, or the complete apneic episode where we're not moving any air in or out. That's why your patients usually will like have a lot of wake ups at night, because your body can't naturally in its sleep work hard enough to overcome this increased resistance, so then it causes you to wake up. So a lot of your patients with sleep apnea will complain that they have interrupted sleep, or they're up multiple times a night. That period of apnea means that there's no tidal volume or air movement, so air is not moving in or out. We're not doing the gas exchange, and because we're not doing the gas exchange, then we've got hypoxemia and hypercapnia, which is hypoxemia, like we learned about in the previous lecture, is the lack of oxygen in the blood, and hypercapnia is the retention of CO2. Obstructive sleep apnea manifestations. So the first and foremost, a lot of people notice that loud snoring, the snorting, witnessed apnea, so where you just, like somebody witnesses that you go a long period of time where you just don't take a breath in your sleep. That gasping during sleep, the recurrent wakes, so your body's literally having to wake itself up to breathe, because like we talked about, your body can't overcome that on its own, so it's literally going to wake you up. Choking, sometimes you'll even hear your patients or your family members, whoever has sleep apnea, literally start to like choke in their sleep. Usually the biggest manifestations and how we end up getting diagnosed with sleep apnea is the 3 S's: snoring, sleepiness, significant other reports it. So snoring is usually your big one. Everybody knows somebody that snores. Sleepiness, because your patients are getting these recurrent wake ups, so they're not getting good deep sleep in their sleep because of the fact that their body is hypoxic and you're not getting enough oxygen and you're not doing that gas exchange. You don't get good rest, and so your patients will be chronically sleepy. They will want to nap all the time, or they will fall asleep. Anybody have a dad who, if he gets kicked back in a recliner watching a movie, and he's like, "Oh, I'm watching the movie," and 5 minutes in, he's snoring and sleeping. They have a hard time like keeping themselves awake. Especially when they get in those still quiet environments, and then usually like a significant other, somebody in the life that like sleeps around them with them at home, a spouse is usually like, hey, you snore really bad, or hey, you stop breathing in your sleep. You have those apneic episodes. All right, medical management. So the first thing we want to do for diagnosis of sleep history, we want to ask those questions. Do you have to sleep propped up, like sitting up in a chair to feel like you can breathe? Do you get good sleep? Are you waking up multiple times a night? Do you snore? Uh, and then diagnostic testing we can do is a sleep study or the polysomnography. So that sleep studies can be done in two different ways now. They used to only be done in a sleep lab where you had to come in and sleep on the monitors. Now they do this wonderful thing where you can actually be diagnosed with sleep apnea at home through like almost like a little pulse ox device that you wear on your hand, and it connects to the equipment that they set you up with for them to then be able to record your sleep in your own environment at home. Usually that's better for like moderate sleep apnea patients. Severe sleep apnea usually is a little better to be done in the lab. My husband was actually diagnosed with moderate sleep apnea at home through one of those home studies. It was like a sleeve that they put on his hand that had like a little finger pulse ox attached to it. They had him come in the day that he was going to do the study that night, and they downloaded an app to his phone, and then that app then tracked everything that happened in his sleep, and they ran a report off of that and then told us that he was having 7 or more episodes an hour of like apneic episodes. So, which he's always snored. For as long as I can remember, he's always snored. So, wasn't that big of a surprise, but he did start having some of those complications that led us to the diagnosis of sleep apnea. We did start having waking up in arrhythmias out of our sleep and things like that, that then caused us to go have him assessed for sleep apnea. So it really does happen. Make sure your patients are aware of that. Okay, make sure you provide that education. So treatment, everyone's either heard of like a CPAP, right, or an APAP. Your patients may even have them in the hospital. A CPAP is continuous positive airway pressure. Usually your patients will go through multiple mask fittings to find a mask that fits them best, whether it's just a mask for their nose or a mask that covers their nose and their mouth. But that's going to open the airway continuous with that positive pressure. That way, when the airway does relax in the sleep, instead of it collapsing down, that positive airway pressure is going to keep things open despite you being so relaxed, where it tries to close off. Also, weight management. If weight is one of the big contributing factors for this patient or this person with sleep apnea, they're going to really want to work on weight management. They also have APAPs that some patients do, which is assistive positive airway pressure. And that would just be essentially it provides the pressure when needed, when it senses an apneic episode rather than continuous positive airway pressure. It's just going to depend on how severe your sleep apnea is for which one your patient will have. This is different than the BiPAP, okay? CPAPs are usually just for at night for sleep apnea. A big thing with, I'm going to go back real quick. A big thing with treatment on a CPAP, stress that your patients continually use their CPAP. They need to use it every night. They need to use it when they nap. Because of the complications that we can get from sleep apnea, it is really important that your patients use it all the time, even if they're just going to lay down for a small nap. Even if they're like, oh, I'm just traveling one night away and I don't need to wear it tonight. Always stress that your patients are using it as much as possible, even just for naps. Okay. So surgical management. So remember we talked about you can have some structural abnormalities that cause sleep apnea. So if we have structural abnormalities, we can have some of these surgical management. So the tonsillectomy, the adenoidectomy. I'm not going to pronounce that word, but that's essentially removal of the uvula. Septoplasty. So if it's something in the nose and your septum's deviated. Nasal polyectomy. Tongue reduction. So if the tongue is actually like too large or falling in the way. Epiglottoplasty, so if it's the epiglottis that is causing you to have apneic episodes, and then obviously if weight is the contributing factor, the main contributing factor for your sleep apnea, they may have you do bariatric surgery. All right, complications. So this is where we were talking about how I was saying that the complications of this can be pretty severe. So we really want to make sure our patients wear their CPAPs all the time when they sleep or when they nap, because some of the big things we get are cardiovascular disease and cardiac ischemia. So recurrent hypoxemia causes the body to release inflammatory mediators, and we also become insulin resistant. Uh, so this causes like white blood cells to stick to the endothelium, and that causes atherosclerosis, or the hardening of those vessels. So when those vessels get hardened, we decrease and constrict blood flow. So we get cardiovascular disease or atherosclerosis everywhere. Cardiac ischemia, meaning that we're not getting good blood flow to the cardiac tissues. And if we're also not getting enough oxygen in that blood, then we're also going to do damage because we're not getting enough blood flow or enough oxygen to the cardiac tissue. You can have myocardial infarction, which is a heart attack. Patients can experience erectile dysfunction, strokes, AFib, atrial fibrillation. Remember, I talked about this can cause you to go into abnormal heart rhythms because we're doing that cardiac damage. Heart failure or sudden cardiac death. You can literally have a sudden cardiac event in your sleep and die. That's why it is so big that we stress this. Um, it can cause hypertension and arrhythmias are commonly seen due to that damage in the endothelium. That's why we talk about you end up with heart failure and the heart attacks, because we can see an increase in your blood pressure and arrhythmias due to this, and those all put you at risk for heart failure or sudden cardiac death. Okay. All right, nursing management. So assessment and analysis. So first and foremost, we're going to look for that oxygen exchange, that there's no oxygen exchange, meaning that we just cease to have a respiratory rate for periods of time. So our respiratory rate's too low, or we just have, 20 plus second pauses where we don't have a respiration at all. That's going to cause the hypoxia. Remember how we talked about hypoxia is just the lack of oxygen. And then the hypercapnia, which is the retention of CO2. So obviously, if we're not breathing in oxygen, we're not blowing out the CO2. If we're obstructed, it goes both ways. Nothing's coming in or out. So that's going to cause us to retain CO2, and that makes us acidotic, right? Nursing diagnoses. So all of these can fall under things. One of the big things is that this is an airway issue too. So we need to be concerned for like our ABCs, airway, breathing, circulation. So we're going to see like sleep deprivation, risk for decreased cardiac tissue perfusion, and ineffective sleeping patterns. We're at risk for that decreased cardiac tissue perfusion due to the atherosclerosis that we get from the inflammatory mediators sticking to the endothelium and causing that hardening. Okay. Risk for ineffective sleeping patterns. We know that I was just saying our patients wake up chronically throughout the night. They don't get good sleep. They don't get restful sleep. Or they have to like sleep propped up in a certain position, meaning they can only sleep in maybe in their own home and they can't sleep when they travel, things like that. Nursing assessments. So obviously we want to watch our vital signs. We might have changes in our respiratory rate. We might have changes in our blood pressure because we're going to get that hypertension. We might have those arrhythmias. So changes in our heart rate, height and weight. So we talked about like having severe weight gain or obesity is a common cause for sleep apnea. The sleep, rest, and activity. We're going to ask our patients, do you get good sleep? Do you feel rested, or do you feel tired all the time? When you are performing your activities of daily living, do you feel wore out? Do you feel like you can't do your normal functions because you can't focus because you're so tired? Those kind of questions, okay? And then because of the fact that we talked about like some surgical interventions, you'd want to assess for edema, bleeding, and respiratory distress for any of those surgical interventions done in the airway or in the, throat and mouth, things like that, okay? And then nursing actions, we're going to administer medications as ordered. Usually medications are for like treating the symptoms. So if your patients experience like headache and fatigue, if they're put on like stimulants, or if they're put on anything to help them get like more restful sleep, things like that. And then diagnostic testing, we talked about those sleep studies. Okay. All right. Teaching. We're going to teach about the disease process, instruct the patients on their medication use. We're going to make sure our patients know how to appropriately use their CPAP, that we really stress that they have to wear it anytime they go to sleep, even if it is just a nap. um, Instruct the patients on weight reduction, talk about how reducing their weight can reduce the pressure off of the airway when they lay down. All that excess weight is causing can cause pressure on our airway. And so if we lose weight, sometimes we can see reduction in sleep apnea altogether. And some of our evaluation of outcomes, some of the things we want to see, obviously, we want to see that our patients are getting good oxygenation. That's like a first and foremost. We want to see improved sleep patterns, fewer night wake ups, less drowsiness and sleepiness, fatigue during the day, improved mental alertness, and less irritability. You get irritable when you're not sleeping, when you're not getting oxygenation. It can cause changes to your mental status, okay? All right, laryngitis. So laryngitis is inflammation of the voice box or the larynx from things such as overuse, irritation, or infection. You might have heard some of your favorite pop stars getting laryngitis and being like, oh, I have to cancel my concert because I've got laryngitis. And that's a lot of the times from overuse or irritation to the larynx. And then we can also see like infections sometimes cause this. Typically viral, not necessarily bacterial, could be, but typically it's viral. And then we have acute or chronic. So acute is like, I don't know if any of you've all experienced like being a summer camp counselor and you've been hollering all week and you end up with laryngitis. That's like an acute. Or chronic would be like, I've got this going on all the time. And then we'd want to make sure that we don't have some sort of like underlying condition of laryngitis. And then manifestations, you're going to see like loss of the voice or hoarseness. You could have like where the patient's voice is just hoarse so they can talk in a whisper, or they might not be able to get sound out at all. Tickling or rawness in the throat, a sore throat, dry throat, cough. And some of the medical management we can do is really just supportive care, fluids, and then antibiotics. If it's bacterial, fluids are usually fine unless there's like a contraindication for your patient to not get fluids. Putting your patients on vocal rest a lot of the time is one way that we manage this. Tell our patients that they just need to not talk. If you put your patient on vocal rest, you can get them other ways and modalities of communicating, like whiteboards, things like that. Nowadays with cell phones, a lot of people can just use their cell phones to communicate via text messages and that kind of stuff. Okay. Laryngeal trauma. So this is relatively rare. It's seen in about less than 1% of blunt traumas. So it's not going to be super common that you run into a laryngeal trauma. However, if you do, it is a medical emergency. We see this happen more prevalently in males than females. Females do have a um, a different shape to their neck that could make them more vulnerable, but males are typically involved in more of these high risk things for it, such as contact sports, race car driving, MMA fighting, that kind of stuff is where you're going to see it's usually like some sort of blunt force trauma to the larynx that causes this. You don't see this a ton because of the fact that you've got the hard bony structures of the cervical spine posterior, so in the back of the neck. And the mandible is like superior and anterior, so that usually causes prevention of like direct injury to the larynx, but it can happen. You can see it in things like assault, crush injuries, and NVAs, strangulation, gunshot wounds, or stabbing. So that's why we do go ahead and talk about it. So like we talked about, the pathophysiology is usually blunt or penetrating traumas. So you've either gotten hit in the neck or stabbed, shot. You can also get it from ingestion or inhalation of a certain agent, like a chemical agent, or even your patients that are intubated. Pressure from prolonged intubation. So those patients that are intubated for a long time in the ICU per se could experience pressure from the endotracheal tube that causes this damage. Okay. Laryngeal trauma, so clinical manifestations. So your patient could have hoarseness, pain, stridor, so stridor's that wheezing both in and out, so we hear wheezing both with air in and air out. Dyspnea, dysphagia, so that difficulty swallowing, and then the hemoptytosis, which is that blood in the sputum that comes up, okay? Laryngeal traumas diagnosis. So physical inspection of the neck. So we're going to inspect for any swelling, redness, trauma to the neck, such as like strangulation marks, swelling from blunt force trauma, penetrating wounds. Then we can do a cervical CT, a fiber-optic laryngoscope. You'll see those used in like intubations and things like that. It's got a camera on the end of it. That camera allows us to see down in to the larynx, or that flexible bronchoscopy. Remember how we talked about the bronchoscopy is like a little camera on that flexible end, like guide wire that goes down and can look and take pictures. Treatment, so we're going to ensure that we maintain a patent airway. That is the first and foremost important thing with a laryngeal trauma, is that we are at major risk of losing our airway. So we have to prioritize keeping our airway patent, even if that means we have to intubate our patients to protect them from losing their airway. As awful as that sounds, to have to knock somebody down and intubate them to protect an airway, sometimes it is best, because if they've gotten trauma or swelling or edema to that airway, we may have to go ahead and establish an intubation before that airway completely closes off, because once it closes off, then we have to go more invasive routes of creating an airway, such as a tracheostomy, in order to get a patient air, essentially get them oxygen. Management, so sometimes you can get like a hematoma that forms in there, so we could evacuate hematomas, repair lacerations, or, opening traumas, and stabilizing any repairs or fractures. So, if this is due to like a trauma that's happened in your neck, you're at risk for, cervical spine fractures. If you suspect a C-spine injury or fracture, we have to maintain C-spine in the neutral aligned position. Usually your patient gets like a C-collar, or we really stress putting your patient, like on a spine board and C-collar until they are cleared of that before we move their head and neck around, okay? Nursing management, assessment, and analysis. So we're going to look at assessing like related to the injury or edema. So like we talked about, inspecting the neck, looking for signs of injury, asking those questions if your patient can tell you like where the trauma or injury has come from. Our nursing diagnoses obviously are centered around our ABCs, airway, breathing, circulation, and we are at major risk of losing our airway with this, for our airway to completely close off. So, ineffective airway clearance. If we're not getting air in and out, then we are not getting breathing, which means we're not getting gas exchange, so impaired gas exchange. And then even if we are able to breathe and move air, the swelling in our throat makes us a risk for impaired swallowing, right? So it makes us a risk for aspiration, because we can't swallow effectively. So we need to prioritize those things as our nursing diagnoses. Vital signs. So your respiratory rate can increase. Your patient will become restless, irritable, anxious. If you feel like you can't breathe, like I was talking about earlier, you're probably going to get anxious, get agitated. You're going to hyperventilate a little bit. You're going to increase your breathing, maybe even increased work of breathing too. And your patient may be really struggling to get air to come in and out. So be monitoring for that in your vital signs and your physical assessment if they're using any um, excess force to move air in and out, if they present agitated, irritable, or with anxiety, okay? Also should assess like their ability to swallow, hoarseness, looking for those signs and symptoms to identify this early. The earlier we identify laryngeal trauma, the better our outcome is. Because like I said, we want to be least invasive first before we have to get most invasive, which would be that tracheostomy. So if we can identify signs and symptoms first and try to treat inflammation before it comes to the point that we lose the airway, that is the optimal goal. Okay? So some of the actions. So a tracheostomy tray and emergency equipment at the bedside is really important. You as the nurse will not perform the tracheostomy. However, knowing how to set up a tracheostomy tray and what equipment you need in the event you see this trauma is really big, especially like if you decide to work in an ER. My previous experience is in the ER, and we actually trained and ran drills on pulling out a tracheostomy tray, making sure you knew what equipment was supposed to get set up with your tray and how you wanted it set up at the bedside for the physician in case the physician had to perform an emergency tracheostomy on a patient to maintain an airway. Sometimes when we get a tracheostomy set up and we get a patient ventilated through that, we might use humidified air. Just know some places will and some places won't use humidified air. Be familiar with what it is, though. It helps decreasing that dry mucosal membranes and irritation from oxygen. Elevating the head of the bed, like we talked about in our first PowerPoint for this module. Sorry, I'm gonna go back there. The first PowerPoint for this module, when we elevate the head of the bed, that is actually an airway intervention. When we sit up, we're able to breathe a little better. And then aspiration precautions. Remember how I talked about when we've got the swelling in the airway, we're really at risk for choking, aspiration, not being able to swallow. So we may want to put them on aspiration precautions, meaning that we get them on like thin liquids, or potentially even being NPO. If they're NPO, then we need to look at other ways to make sure that they stay hydrated, enough fluids, and supplementing that if we have to put them NPO until the swelling gets better. Teaching, so we need to teach to report symptoms to the healthcare provider. Like I said, it is a really big deal that we identify this early. Identification and intervention is important. So we need to educate that if they experience these signs and symptoms, they need to speak up and tell us. Voice rest, we talked about that with laryngitis as well. If we've got trauma to the larynx, we need to go on vocal rest so that it has time to heal, so we don't cause strain and permanent damage to our voice and our vocal cords. And then evaluating care outcomes, preventing airway compromise. Like I said, that is the number one goal of this, is to prevent us losing the airway. Okay? We want to make sure that we're prioritizing those ABCs and early intervention and making sure that our patient has a patent airway is the big deal here. We want to make sure that our patient is able to ventilate and oxygenate. All right? And I think that is it for the end of the slides.